Good afternoon, everybody. Today I wanted to talk to you about an experience that I had while I was on my very first rotation here at UMC. I was on an infectious disease rotation, and so I got exposed to a lot of different bugs and even some antibiotics that you might see on a daily basis. And I wanted to talk to you about one of the situations and patient cases that I encountered while on this rotation that I had never heard of. You know, most of the time when we get out of school, you know, we may not be able to recall everything that we've once been taught or that we've learned. But every now and again, something comes up that you can say, I really don't know if I've ever heard of that before. That's brand new to me. And so that's one of the reasons why this particular bug stuck out to me. It's a Stenotrophomonas multifilium infection. It was a bug. Just a quick background on it. Stenotrophomonas is a multi-drug resistant gram-negative bacilli. It's an opportunistic pathogen that you'll see mostly in immunocompromised patients or patients that are at high risk to become immunocompromised. It's also associated with a high morbidity and mortality in severe immunocompromised and debilitated individuals. So this is a very tough bug that you see a lot with patients that are at high risk, such as cancer patients, HIV patients, or elderly patients that have just been in the hospital for a long time. So kind of a quick review as far as the microbiology of the bug. It's an anaerobic, non-fermentative, gram-negative bacilli. The naming, I always like to kind of go into the naming a little bit because it helps me remember the bug and kind of the origins, and sometimes that can help you just remember different things and certain unique aspects of it when you're on rotations. It was first isolated in 1943 and was named Bacterium bucari. It was classified with Pseudomonas later on. So it's already been named a couple different times, and then after a few years it was changed to Xanthotrophomonas, and finally it was changed to Stenotrophomonas in 1993. So I like to remember this as it was originally at one point was associated with Pseudomonas, so I kind of always try to sort of associate with that. Not that should necessarily direct your therapy, but it's a gram-negative bug and it can have a lot of resistance. So that's just kind of a little trick that I use to help kind of remember with this bug. It's actually unique in the fact that this is the only Stenotrophomonas species that's known to infect humans. It has other close genetic relatives, but they are all plant pathogens. So this is the only actual pathogen of this family that actually infects humans. It shows a tendency to adhere to foreign materials and surface before biofilm. So obviously this kind of goes back with patients that are typically immunocompromised. They may have several different ports. They've been hospitalized for a long time, so they have many different lines. And so this bug likes to hide out in those lines a lot. But also it can be located anywhere. It's intrinsic and/or acquired resistance mechanisms to a number of antibiotic classes, such as beta-lactams, aminoglycosides, carbapenems, and fluoroquinolones. So this is obviously a very, it's a multi-drug resistant organism. It expresses beta-lactam resistance. It uses a zinc-containing penicillinase and a cephalosporinase. And with the aminoglycosides, it has an aminoglycoside acetyltransferase that confers resistance to the aminoglycosides. And also, some of these bugs can express, can have efflux pumps, so they can have efflux pumps. So, as you can see here, you can already tell with this bug, they have many different mechanisms of acquiring multi-drug resistance. As far as the epidemiology, it's associated with a high morbidity and mortality in severely immunocompromised individuals. People that are at high risk for this infection is admission to the ICU, HIV infection, malignancy, cystic fibrosis, mechanical ventilation, or previously used broad-spectrum antibiotics. So just generally what we consider a patient to be immunocompromised for many different aspects. This is a patient that you would be concerned about acquiring this infection. As far as its incidence, it's not a very common bug. This was actually my first run-in with it. Some case reports that I found, it has an incidence of 7.7 to 37 cases per 10,000 discharges. So So this is not a very common organism, but I will say that since I've seen it once, I think I've been seeing it 2 or 3 times since then. So I'm actually starting to see it more throughout my different rotations. Now, to get down to the basis of treatment, you always have to make a decision to treat or not with this bug, because a lot of patients can be colonizers, so you wouldn't always necessarily want to treat this infection. So if you ever have a culture, the first thing you want to realize and you want to evaluate is, okay, how sick is this patient? Where did the culture come from? Is this a patient that is colonized, or is this a patient that I need to treat because this is an active infection? So when you're looking to initiate treatment, one of the first things you want to do is you want to look at, do they have clinical signs? Does this patient, are they running a fever? Do they have any other issues going on? What's their white blood count looking like? So for example, like if a patient was showing signs and symptoms of pneumonia, and you got a respiratory culture, and that culture came back as being positive for Stenotrophomonas, then yes, you would want to treat the Stenotrophomonas. Also, like I have noted here, if you have positive cultures from a sterile site, such as blood or peritoneal fluid that did not come directly from a line, that may be an instance where you're going to be, okay, like this could be a serious infection here. Where you want to defer treatment is whenever you have a sample, like from a urinary catheter or a drain, and they're not really clinically showing any signs of an infection. You would look and see if this patient running a fever, do they have a white blood cell count, and all the other different signs and symptoms that you would normally evaluate to see whether or not if a patient had an active infection. But I also encourage you to be careful with that, though, since this bug is specific, or not necessarily specific, but has a higher tendency to be associated with immunocompromised patients. Some of these patients may not be giving off all the traditional signs and symptoms of being sick because they're so immunocompromised. So that is something that I would recommend that you always just kind of keep in mind. And this is going to be a very patient-specific whether to treat or not to treat. As far as antibiotic selection, the drug of choice is Bactrim, and you dose it 15 mg per kg per day, divided doses. That typically tends to be the drug that you turn to first for this bacteria. Every infection that I have seen thus far has been resistant to Bactrim, so take that with a grain of salt. Also, you can use Levaquin, minocycline, tigecycline, and rifampin. Obviously, the rifampin you want to use in combination with another antibiotic because, like I discussed earlier, this bacteria has a tendency to form a biofilm, and so that's the theory with the rifampin, is it can help penetrate the biofilm and help get more of the active drug inside into the seated infection. And as far as duration of therapy, it's typically 14 days. You can see it longer. For instance, I've seen it for 3 weeks. So this is something that's patient-specific. If they have an infected line, are we able to take it out? If not, that can influence therapy as far as the duration. So it's kind of patient-specific, obviously, but generally around 14-day course of antibiotics. And so I have a quick patient case that I was wanting to share with y'all, and we'll kind of discuss it and go through it. We have a 45-year-old white female with stage 4 squamous cell carcinoma of the cervix, diagnosed 5/28/15. With mets to the bone and liver, the patient was admitted on 8/12/15 with urosepsis and symptomatic anemia. The urine culture on 8/11 grew coagulase negative staph, Stenotrophomonas, and Pseudomonas. So obviously this was a very sick patient. She grew a little bit of everything across every spectrum in this. So one of the first things you want to look at is, okay, how sick is this patient? So one of the first things I discussed earlier would be, okay, is this patient immunocompromised? They have high risk. Do we need to treat the Stenotrophomonas, or do we need to just treat the coagulating staph and the Pseudomonas? So we looked, and obviously she's a cancer patient. She had been receiving chemotherapy, and her white blood cell count was not elevated, but we were thinking that was probably due to the chemotherapy that she had been receiving at the time. So then we looked and said, okay, well, does she have a fever? The patient was consistently running fevers. So when we kind of put all this together, the first thing we thought was that we should treat all the infections, including the Stenotrophomonas, that this was not a typical colonizer, that this could be contributing to her infection. So whenever we first got the patient, we wanted to, obviously it has a lot of resistance, so we wanted to start empiric therapy. When we started her on tigecycline, give her 100 milligram dose followed by 50 milligrams twice daily, awaiting sensitivities. And we get sensitivities back, and it's resistant to Bactrim, and the next drug that you typically look at that come back with sensitivities is Levaquin. So the two first drugs that you kind of look at to treat this bug with the drugs was resistant. So then we left her on the broad spectrum to continue the therapy and wait other sensitivities. So then we had to request sensitivities for possibly ceftaz to see if that would work, or minocycline. And then it turned out that it was resistant to ceftaz, but it was susceptible to minocycline. And so we was able to swap this patient to oral minocycline 100 milligrams twice a day upon her discharge. So this was just an infection and a bug that I was not used to and I wasn't familiar with, and I thought it was very unique in the fact that it showed a very high level of resistance, especially when you go to reading of the best ways to treat this bug. All resources say Bactrim, and I have yet to see Bactrim be able to be used to treat this bug here so far. And so I just wanted to discuss that and share that with y'all with my experiences of this case. I thought it was very interesting, all the stuff that we saw. Do I have any questions or comments about it? Yes, ma'am.
So is the resistance was developing this maybe better for trials? Because almost all of the items that I have in these are I'm at the factor.
Okay.
So
Take what you see on the anti-surface array salt. If they use this term, if the general service manage it, we're probably not going to see it. That's usually your susceptibility. It's increasing. Bare minimum usage adherence, like since development is those short adherence on the roof. That's a shock to see these. So the fact of seeing more, and the fact that bare minimum is just ubiquitous. A lot of these resistance genes will co-locate and sometimes transpose on. Sometimes when you see it, it's dual. Steno is just bigger. It just is because there's not a lot to do. Unfortunately, not antibiotic populace down yet. Not in Steno.
Okay.
Close.
So I think this is the only patient that I've actually been on involved with the team and had this patient come through the service. I've talked curbside with some other people, I believe, in Allen using this book several times, and I haven't, the 2 or 3 instances, or 3 or 4, I guess I've seen so far since coming in contact with this patient, I believe Bactrim and Levaquin resistant in both of them.
This is kind of an atypical innovation, because most people seem to be where Allen disease, which is in that respiratory, typical pseudomonas infection, they've got organs and also everything you do. Did y'all do e-tests on this? I think you Dr. Snow.
We did e-test for, I believe, with the minocycline and ceftaz. And correct me if I'm wrong, I believe that we tried to also do the tigecycline, but they were not able to.
They don't have tigecycline tests.
Okay, so that's one of the reasons why we couldn't get the tigecycline.
Yeah, they'll give you a number, which is just dropping the disc. There's no breakpoint set for steno. Comes back at 18 millimeters. That's why I asked them to hate this infusion. I'm not saying qualitative, RSA versus not. We'll see if this drops the disc. You effectively wasted like a while. I'm just not asking to do it. And it just doesn't mean anything. There's no number you can associate with it.
that patient wasn't it only 50?
This patient or?
No, the one that had to read that one. I think it was like just under the higher line cutoff. They don't know what polymace in.
Could be polymace. Usually, like some places with use 14, it doesn't diffuse through the artery. It's called all the acids. Tigecycline uses 19, but that's enterobacteriaceae. It's not also put in. So, I'll walk in a bug. Yeah, I do heat tests.
Right. Do any of the other cycles?
This one?
No, they had all viscosity covered up.
No, tigecycline basically the exact same drug. They both are active. It's cheaper.
Well, hey, but all the drugs that we use to treat this cycles, I think 500 meals twice a day. Probably mixes 600 meals twice a day. So, maybe juice there.
Any other questions? Okay, thank y'all.